all and allocation concealment. There's underpowered studies. There's lack of data in the standardized format to be used for meta-analysis. There is lack of complete data amongst the trials, and there's absence of long-term data. The reason it did not work well in the UK is mainly it cannot be left long. It has radiation, and the radioactive seeds is mainly hard radiation that one you want. It's mainly used for treatment. It needs nuclear medicine department and needs an RSAC as a license, which is not easy to get. Loads of paperwork. You need to know each seed where it is, when it's in the patient, in radiology, in theaters, in nuclear medicine, in pathology, and every seed will need to be retrieved and sent back, because if you lose one, it's a major disaster, because this will keep on emitting radiation for years and years, and it can be a big problem for the nuclear medicine department if they lose one. And when they cut the specimen in pathology, it easily can go, or can easily be go in your suction in theater. The mag seed, I remember a few years ago when I was the registrar with Ash, who's also sitting with you today, we've done the Sentimag trial, where we used the mag trace and the SPIO at that stage to do sentinel node biopsies led by Mike Dweck in Guy's Hospital with good results. And since then, in 2016, the seeds appeared and they started using them for localizing breast lesions. And we'll look at the data from the UK about that. And I'm not going to touch on the MAG trace and the use for sentinel node biopsy, because I think Andreas will have a long talk about that. The MAG seed has the largest data set for breast and axilla. There is a large data set from the USA, and there is one from the UK that we'll mention here. It's a small seed, small needle, used for breast and axilla, and it's robust. You cannot break it because you're using the physical characteristics of that seed. So the seed cannot go wrong. But the probe is delicate, so if you drop it, you can break the probe. It's more challenging if bracketing is needed, and I'm sure also Andreas will talk about that. You cannot use metal instruments, but by the way, the plastic instruments that they provide are brilliant. They're very good instruments, and there's always issue with MRI compatibility. And there is good data also about using it for targeted dissection with nearly 100% retrieval rate of the targeted node. And it's an effective marker. There's no migration. We have used MagSeeds. We have used also localizer. We have used Savvy Scouts in the unit. And one of the points that the pathologists point that with the MagSeed, there's lots of fibrosis. It's stuck to the tissue. The radio frequency identifier device, we have used it quite a lot in Aberdeen. It's very easy to use. The reader is really small. It's just bigger than an iPhone. And the probe is quite tiny, like a pen. And the probe is disposable. And you can read using the probe, and you can read using the reader. So if you're operating on multiple sites, you can easily take this handheld device with you and use it. Each tag has a serial number, so if for multiple lesions or multifocal multicentric, you can know exactly that this is the tag number blah, 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 and this is the tag number 2, and you know that this is associated with this pathology and this is associated with this pathology. And pathologists like it because it slides easily and they can cut it out from the specimen quite easily. The problem is that we don't have much data set. We have finished collecting the data with the iBranet, and the paper is being written. The results are very encouraging, very similar to the MagSeed data, but this is will be submitted the next month or two. The other problem is that the needle is quite large. It's a 12-gauge needle, and the tag is quite large, and it's quite hard to push it sometimes in larger lesions. And for screen-detected lesions, it's bigger than some of the screen-detected lesions. That can be an issue sometimes. Some use it for the axilla, but the other problem with this, it has no license to be used in the axilla, though there has been reports, I think, from Gateshead and Newcastle that they used it for the targeted dissection. And I'm hoping that the company will make this smaller and get the license for that. Of course, there's the Savvy Scout, which is radar also, can be inserted early, can be used for the axilla, and we've used it. A small amount of data can be broken, which is very unusual, but also can be disabled by diathermy and serious pintuition. It's a true magnetic, not paramagnetic like the MagSeed. And you can use metal instruments up to a certain extent, but they have little data sets still. And we're not going to go through this because I'm sure this has been covered in the previous talk. So the iBranet is a collaborative group that if there's any new localization technique or a new innovation that needs to be looked at, we set a some studies, and we look at that in multi-center studies to see if the data showing that this is safe to use. And one of the first studies on the localization was the magnetic seeds, and they compared the seeds um, with the wires. The primary endpoint for the study was identification of the index lesion, and the secondary endpoint was margins, specimen weight, safety, and cancellations. And another thing which is, I think, quite excellent that has been done by the iPlanet is we're not only looking at numbers, we need qualitative data, shared learning experience. You learn sometimes much more from talking to your colleagues. So after finishing each of the studies, the users of that localization technique, they meet on Zoom, they discuss what difficulties they had pre-op, post-op, and how did they manage those. And that's how you identify those little things. For example, if you touch the service scalp with a diathermy that can stop it working, or for example, for the localizer, you can, if you sometimes you struggle putting it in the lesion, we put it posteriorly. In the MagSeed study, there was 2,450 records. After excluding some of the patients that not fit the criteria, they had 2,300 records, and roughly similar right-hand side and left-hand side localizations, about just under 1,000 mag seeds and just about 1,200 wires compared with that. All had single lumpectomies, all had lesions that are less than 5 centimeters, and patients that had neoadjuvant chemotherapy were excluded. And the primary endpoint, the index lesion was in the specimen in 99.8% of mag seeds and 99.1% for wires. This is a significant p-value that is not relevant clinically at all. They're both good in what they do. They both have very high localization technique. And this is one of the occasions that you see statistics does not make any sense. So if you look at the magnetic seed and the wires in comparison to ultrasound scans versus stereo localization, you'll see that with the mag seed, it's nearly 100% for ultrasound scan localization. And for the wire, it's 99.6%. It's very minimally lower for both the wire and the mag seed, but there will be selection bias in those cohorts. And if you look at the positive margins was about 13% with the mag seed and 15% in the wires, which is not significant. And as I mentioned, the shared learning experience is always great to meet with other colleagues, have a look at what difficulties they have encountered and how they solved that. And that was published in the European Journal of Surgical Oncology. And you look at the preoperative issues, intraoperative issues, and postoperative issues. And you get with a learning outcome that is not based on numbers from localization, that's based on experiences, which is something that sometimes we lack in the literature. There's a chance to get involved. So the radio frequency tag has closed, but there's still recruitment for the serious medical and the service scout if anybody is using them. And I think they're open for international collaboration. But what is important is the Mayday study. So this is led by the EU Breast, and it's great to have Thurston with you. So if you're interested in this, please speak to Thurston and to Bahadir. And the EU Breast is a collaboration between the EU Breast and the iPlanet. And we're trying to pool data from all across the world about the different types of localization techniques to see if there's any difference between any of them. Turkey is one of the countries that is part of this. So if your unit is not part of the melody, please speak to Thurston or speak to Bahadir and get involved in this. So there is lots of promising new technologies. All has advantages and disadvantages. Nothing ticks all the boxes yet. And the wire is needed every now and then. Thank you for listening to me. I'm happy to take any questions. Thank you.
Thank you very much, Dr. Masanat. And he's attending a congress, so he won't be taking any questions. So this is the end of this session, and we have a coffee break now. See you in the second session.
currently head of the breast center in Esslingen, Pilder Clinic, and consultant of the University of Ulm. He is also a member of German Guideline Committee and chairman of the EU Breast Research Group. As you know, in the last 10 years, the optimal management of patients with an initially positive axilla after neoadjuvant chemotherapy has been one of the hot subjects discussed in the surgical community. Whether patients with an axillary complete response following chemotherapy might be treated with sentinel lymph node biopsy or targeted axillary dissection is under investigation of the prospective trials, including Allianz and the currently ongoing Aksana Neosent Turk. And Dr. Thorsten Kuhn is going to talk about neoadjuvant chemotherapy and the axilla. Yes, Dr. Kuhn.
Okay, thank you very much, Neslihan, Mr. Chairman, ladies and gentlemen. Thank you very much for giving me the opportunity for the second talk. And unfortunately, I have to leave after the talk, and this is not because of interest. I would have liked to stay much longer. It's the only flight to Germany, and I have a family meeting tomorrow, so I really, really, really regret having not the opportunity to staying longer. So these are my disclosures. So neoadjuvant chemotherapy in breast cancer was primarily introduced to allow surgery in inoperable cases. But we then learned that it can decrease the extent of surgery in the breast and the axilla. Psychological advantages provides prognostic information. But in recent years, we have seen several trials that show that neoadjuvant chemotherapy improves outcome with regard to recurrences in some subgroups. And so neoadjuvant has really been pushed and has become the standard of care for many patients. So these are the major trials. The CREATE-X trial published in 2017 showing a survival benefit for triple negatives patients who were treated with additional capecitabine if there were residual tumor after neoadjuvant chemotherapy. The Catherine study, you all know this, for HER2 positives, patients with residual tumors treated with TDM1, or the Olympia study for BRCA positive patients with residual disease, treating with PARP inhibitor. So we have learned in recent years that the neoadjuvant approach improves survival, and most recently the Keynote 522 paper was published showing that the neoadjuvant that given pembrolizumab in triple negative patients in the neoadjuvant setting definitely improved event-free survival by 3 years by 7.7%, which is quite a lot. Now, what about the lymph nodes? And these are data from the Keynote 522 patients who have presented initially with node-negative disease and have negative lymph node status in up to almost 95% of patients. So we really have to consider an old standard of performing axillary resection for these patients, and even, and this is the more interesting group, patients who present initially with CN1, 2, or even 3, and under chemotherapy convert to YPN0. So there are 76% treated with pembrolizumab who convert to YPN0, even CN2 and 3 patients, and without pembro is 69. So many patients, even with high nodal burden under neoadjuvant chemotherapy, convert to YPN0. So we have to consider what to do with these patients and avoid full axillary resection. Now, what about accuracy of imaging modality? And we all know that there's no adequate imaging modality showing adequate accuracy to predict the nodal status. And if we compare some ultrasound, MRI, or even FDG PET CT, the negative predictive value is around 50%, which is clipping a coin, probably. So there's no existent imaging modality to indicate nodal involvement. So we need to stage the axilla surgically. So what are the objectives of breast surgery after neoadjuvant chemotherapy? Primarily, it's diagnostic, to provide information on response, because as we have known, PCR, assessment of PCR is important in order to have the indication for post-neoadjuvant systemic treatment. And we also have a therapeutic intent to provide local control. Now, what about patients who present initially with node-negative disease? And we had a long discussion 6 or 7 years ago whether we should do the sentinel node biopsy before or after chemotherapy. And in 2016, the data were presented, and I think it was published in 2018 from Jean-Marc Glass, showing that sentinel node biopsy after neoadjuvant chemotherapy in CN0 patients had a high detection rate, which was important, but also there were very low recurrences. So since assessment of nodal status after chemotherapy is important to assess PCR, so it was no question that for N0 patients, X-ray staging, surgical X-ray staging has to be performed after neoadjuvant chemotherapy. But what about CN1-2 patients who converted to clinically node-negative status? What about the feasibility and accuracy? And you know, we have the Sentina study, we have the ACOSOC study with very similar results. And if we compare the data with regard to feasibility and false negatives with sentinel lymph node biopsy in the upfront surgical setting, and this was NSABP 32, which had a false negative rate of 9.8% compared to 14 point something in Sentinel and ACOSOC, you can see here. And the surgical community decided at this point that a false negative rate of more than 10% was not adequate, was too high. And therefore, for many years, we continued to perform full axial lymph node dissection. For me, most importantly, is not really the false negative rate, because we will discuss the significance of this false negative rate. It's rather the detection rate and the feasibility. Because if you do not identify a sentinel lymph node, you have to go to full axial resection for staging. So these data from Sentinel in one arm at that time, in patients who were clinically node negative, in one arm of the Sentinel study, we performed the sentinel node before chemotherapy, and we had a detection rate of 99.1% with more than 100 sites. So this is easy, this is reproducible, it's a fantastic technique. But after neoadjuvant chemotherapy, the detection rate was only 80%. So something happens after neoadjuvant chemotherapy. And regarding the false negative rate, what we did not know, we decided, because we all thought it was like that it was too high. But we did not know how this translates into recurrences or disease-free survival. And I give you one example. What does it mean? If a patient has a 30% chance of residual disease, what's the risk of missing a positive lymph node? With a false negative rate of 10%, it's 3.0%, and the false negative rate of 15%, it's 3.5%. Not really clinically significant, I would mean. Okay. What is the explanation for increased detection failures and false negative rates? And these are very old pictures I took in the early days of sentinel lymph node biopsy when we worked with the blue dye technique. So this is a positive lymph node, and this is a picture I took maybe 20 years ago. So this lymph node does not take up any tracer, but we can identify the lymph node by the blue stained lymphatic vessel. But if we don't see the vessel, we don't see the central lymph node. There are very slight staining here. What's the reason? Because there's no lymphatic tissue that can take up any tracer. And what happens? So this is a detection failure. We will not detect it because this lymph node will not take up any tracer, whatever. And even if you have a good response, there will be fibrosis and there will be no lymphatic tissue left to take up a tracer. And what happens? Either we don't detect the node, or there will be a bypass to another lymph node, which will then end up in a false negative case. Now, how can we avoid, and now we come to our discussion, how can we avoid the high false negative rate of sentinel lymph node biopsy? Now, this is from the NCCN guidelines, suggesting that using a dual tracer or by removing more or 3 nodes or more, we could avoid false negative or reduce the false negative rates. Well, we are not supporting so much this idea in Germany because we have the Sentinel trial. And these are data from the Sentinel trial. In only 66% of the patients, 2/3 of the patients, we had 1 or 2 sentinel lymph nodes. And only 34% per patient, we detected more lymph nodes, simply because there was no tracer uptake of the lymph node. And according to the protocol, every lymph node that took up tracer was defined as a lymph node. So where do 3 or more lymph nodes come from? Another issue is the dual tracer. And we do not perform dual tracer. Why? Because we have the Sentinel trial. And it's the only trial, I think it's often overlooked, the only trial that has a multivariate regression analysis for different factors related to detection. And you can see there is no statistical significance